We'll jump in and get. I hit the wrong button. Sorry about that. Here we go. All right, you should be able to see my screen there. The nice thing is we have a small group, so we can have plenty of dialogue and conversation. So I will invite you to drop questions or comments or points of discussion into the chat, and they'll help monitor that for me. I can't see all of those readily, and I'm not great at multitasking anyway. So I'll pause for some prompts and feel free to jump in with those. But the small group will be nice for that and allow that to serve us well. It's interesting as I get started here, the picture that, and I'll be honest, I didn't pick the picture, but it's the picture that you see right now on the right, is a picture of our respite rehab and reentry center. It is the lobby to a building that's 108 beds, residential and respite and crisis focused, not acute or inpatient, that serves individuals that are at the intersection of homelessness, criminal justice involvement, and serious mental illness. And so it's probably an app slide, although I don't think they intended it, because it does get to how do you begin to create value broader than just the actual services delivered. And we found great success and impact in the programs that are part of that unit and a part of that facility. But moving into the actual topic, my name is Wayne Young. I have the privilege of being the CEO at the Harris. It does get a little confusing sometimes between Harris Center and Harris Health. Sometimes I myself have to make sure I say the right word. If you're not familiar, Harris Health is our public safety net hospital here in Harris County, but we are the Harris Center for Mental Health and IDD. I'll talk a little bit about who we are and what we do. I'll talk a little bit about trends, because you can't talk about why this is important without, at least reinforcing the context. I suspect many of you know it and are probably more familiar with it than I am, but it seemed awkward to just literally jump in. And then we'll talk about some of the key components and challenges associated with leadership in value-based care climate, and then kind of a bit more of a dialogue around integrated care and how that blends with our approach to value-based care and how we see those things as kind of connected in ways that aren't separable, really. So let's start with my mention of the Harris Center for Mental Health and IDD. We are the local mental health authority for Harris County, which includes the city of Houston. I saw there's at least one or two people from other states. And so in your states, it might be called Community Mental Health Center. It might be called Community Services Board. There's a few different names for what we are. But at our core, we are the safety net behavioral health system for the 4.8 million people that live here in Harris County. It's a big task. We are a fairly large organization. We have about 2,670 employees right now that serve almost 90,000 people, unique people with mental health and IDD needs. In case there's not familiarity, IDD is intellectual and developmental disabilities. Last year, we delivered almost 1.9 million services to those 90,000 individuals, and our operating budget was $325 million roughly. So we're a large behavioral health and IDD organization. We've got some size to us. And frankly, when it comes to the value-based conversation, I honestly think that size is helpful to us, right? There's a scale there that we can impact. There's also some insulation from a little bit of that chance that you're taking, a little bit of that risk. If I make a $2 million mistake, it'll be painful and it might have consequences for me personally, but it won't bankrupt my organization. You're in a smaller organization, that $2 million might be everybody's raises next year, right? So I understand that our scale gives us a little bit of cushion that some centers and some behavioral health organizations may not have. If you think about our organization, we structure around kind of your traditional mental health treatment, IDD services, a comprehensive psychiatric emergency program. And I'm not going to get into the uniqueness of all of our services, because frankly, that's an hour in and of itself, is just talking about our service delivery system, if not a little more. Justice involved services, we have a pretty big footprint in that space, as well as our crisis and access line. We do answer 988 calls for about a third of the population of Texas. So far, since last July, we've answered almost 50% of all the 988 calls originating from Texas area codes. This is a little bit around our scope of services, though. And as we've had conversations around value-based care and with managed care organizations, there's often been a lot of attention and focus paid to the kind of robust service delivery system, because that's a nuance that is a little hard to quantify its ability to help us be successful in this, but we certainly think it's related, right? We think if we were smaller and didn't have the ability to care for people at scale, it might be trickier. But you can see there's a thousand different ways to kind of organize and try and communicate this. This is by no means an exhaustive list. We did a count the other day, and I think we have over 90 discrete programs that are part of our service delivery continuum here. But it kind of breaks it out at least into some bands of services that help give you a sense of the array. This is not limited. This is not exclusive to or inclusive of all of our services, but it gives you a ballpark idea of it. So let's frame the behavioral health landscape a little bit. If we're going to talk about value-based care, we have to talk about some of the reasons why we would want to drive that direction, as opposed to trying to sit comfortably where we are. First is that 1 in 4 adults be diagnosed with any mental illness, which is a challenge in and of itself, right? 20–25%, depending on who you talk to and whether it's current or lifespan diagnosis. Part of the challenge with that, though, is of the 57.8 million adults with any mental illness, only 47% of those received treatment last year, right? So you began to worry about why that is and the consequences of that. Similarly, for the 1 in 6 adults who meet criteria for substance use disorder, only 6% of those individuals received treatment last year. Now, there's a little caveat to that I'll say, because in a minute, I'm going to talk about some of the reasons for that. On the adult side, almost all of that 94% that didn't receive treatment didn't want treatment, right? They didn't have insight into their need for treatment. They recognized the need, but weren't interested in it or thought they might be able to address it on their own. So I don't want to create a misperception that there's people standing on the street corner waving down treatment vans and they're not being able to get in them, right? But there is still some pretty significant challenges and consequences of that number. Also talking about disproportionality. I mentioned that we do a fair amount of work in the criminal justice system and with those that are justice involved. Here, you look at the prevalence of mental illness and substance use disorder. You compare that with the prevalence of mental illness and substance use disorder in the orange bar, which are those individuals that are incarcerated. And you can see at a glance that huge disproportionality and disproportionate impact. And then in the dark blue, you look at those that are identify as being homeless or without a home. And you see that that continued overrepresentation in those populations. And you begin to get a sense of what might some of the consequences be for that undertreatment or lack of opportunity to engage in treatment, or in some ways, perhaps the lack of effectiveness of some of the treatment options that are available. So 3 out of 5 people with a serious mental illness die to a preventable health condition, right? Most of us have seen the study. It's a little old now, but if you go back to that report, it estimates that somewhere around 28% of people who have a serious mental illness and receive care in the public mental health system will die 28 to 30 years sooner than their counterparts without a serious mental illness that don't receive care in a public mental health system. That 28 years, about 6 years of that, are accounted for by suicide loss. And so there is a certain amount of that you have to adjust because of the deaths related to suicide, but that still leaves a huge number of years that are because of things that you see on the right: diabetes, metabolic syndromes, hypertension, lung disease, cardiovascular disease. I'll get on the soapbox here for just 1 second and talk about the disproportionate rates of smoking and tobacco use for individuals with a mental illness. Any mental illness, those individuals report almost twice as the likelihood of using tobacco, smoking cigarettes. If you look at people the average tobacco use rate is about 15.8% of the population. If you look at individuals with schizophrenia diagnosis, that goes to 70 to 85% of those individuals use tobacco. Bipolar disorder is 50 to 70% of the population uses tobacco. And if you look at the population I serve, that's almost 2/3 of the people we serve. Of that 90,000, I should lower that. Some of the people in jail don't have those serious mental illnesses. So probably of our 65,000 community-based individuals we serve, that's a huge portion. Almost 2/3 of those fall into those 2 diagnostic categories.
Wayne, we have a question from Dr. Gibson. What percentage die from suicide?
So I don't remember that number, but we can certainly follow up with it. I don't, I just remember the years lost. I tried to quantify that because I wanted to try and norm out a little bit, if you could, the data in terms of years lost, but it's a great question. I do appreciate it. I'll take that question though, and answer one thing I can add to the conversation around that. And that is some recent awareness that we have. We spend a lot of time in our system talking about reducing suicide, eliminating deaths from suicide. It's one of our strategic plan goals, is to get to zero suicide. It's probably worth noting in our community here in Harris County, which probably isn't that different than almost any other community in the country, except for its size. In case you're not familiar, Harris County is the third largest county. Houston is the third largest city in the country. So we're big, but our rate of loss of life from overdose is almost twice the rate of suicide. And so despite the fact that our behavioral health system and even our state spends a great deal of time and energy talking and raising awareness around suicide deaths and trying to prevent deaths from suicide, as we should. I'm not saying we should stop that work. I do think we need to add a little more conversation around the loss of life we have from overdose, because it is literally double the rate here in Harris County in terms of overdose deaths from suicide. But I don't know the percentage in that context asked. Was that the only question?
Yes.
Okay. I have a tendency to get on a roll, and so I realized I had not paused at all for a question. So feel free to assertively jump in if I get on another roll. Reasons for lack of mental health treatment. I think most of you probably seen these before. Just so you know, this isn't some kind of weird LPC math. This is the respondents can select more than one reason why they did not seek treatment. So this is in that National Survey of Drug Use and Health, noting that almost half of the people who did not seek treatment identified cost as a part of that conversation. So if we're looking at value-based care, trying to find ways to improve outcomes and reduce cost, that becomes a pretty clear driver of the need for that conversation. Not knowing where to go, imagine for a moment that, you know, you're sitting in your chair in your office and you have some chest pain and you think, man, I think I might need to get somebody to look at that, and you not having a clue where to start to begin to get that care. That's a little bit concerning to me and overwhelming to think about for those that we serve. I'll also just highlight 3 of the last 4, 10, and almost 15%. So a quarter of the people, almost 35% of the people indicated they didn't seek treatment because of negative opinions from others, negative effect on job, and confidentiality concerns. To me, all of that is wrapped in stigma, right? So stigma showing its head again in terms of why people aren't willing to access and engage in care. The impact of these comorbidities and what I would say is probably also the limited engagement in treatment for substance use disorders and mental health conditions often shows up in terms of cost of treatment, right? There's quality of life factors, there's impact functions that we could talk about. But if we're going to focus our conversation around value-based care and the financial implications of that, then it's probably important to talk about the drivers in terms of cost of this. So in the light blue box, you can see that is the cost per member per month cost for individuals with asthma without a mental health or substance use disorder. And then if you look in the orange box, you can see the cost of an individual with asthma that have a mental health condition. And then in the dark blue box, you can see the cost of the per member per month cost for those individuals if they have a substance use disorder. And interesting to me that substance use disorder drives that cost, drives cost for individuals more than mental health, with the exception of COPD. And so this isn't information I came up with. The study is cited there. I'll be happy to send you links or actual papers from most of the stuff I cite. I never want to be embarrassed with having wrong numbers, so I'm pretty diligent about where I gather my information from and the data from. And Milliman is a favorite of mine. They do a lot of really, really good work, I think, in this space. So measuring cost of care. So obviously, I think most of you are probably pretty familiar. We've got 20% of our GDP nearly is going towards healthcare costs, far more than most of our peer countries. Much of traditional care is low value. It is not necessarily adding to improved outcomes in any way. Measuring the cost can lead to more collaborative, efficient, and patient-centered care, working towards the quadruple aim: patient experience, overall health, reduced cost, and well-being. So let's talk for a little bit about the leadership part of this. All that was to kind of set the stage for what I was actually asked to talk about. And so let's talk about a value-based care model and traditional fee-for-service model. I suspect y'all have had or will have more of these conversations and go into details about this, but in its basic principle being reimbursed and paid driven more by quality of care than by quantity. Now, you saw a minute ago, I delivered 1.9 million services to individuals, right? And I'm in a unique place where most of my services aren't reimbursed by a third-party payer in a traditional kind of sending in a bill, getting a payment back. Less than half of the people I serve have Medicaid. Well, less than half the people I have any health coverage at all. 98% of those who have some sort of coverage are Medicaid. So the majority of the patients I serve don't have any payer. And so the state is their payer. We are the provider of last resort when it comes to payers for individuals. And so we use state funds to help offset, but there are still, even in the state system, incidents of care that are calculated. Those services are what drive what make up the required services that the state says these are the things you must do to meet the level of care requirements for these individuals. And if we don't do those things, the state comes back and kind of pops us on the head, and also have to meet certain quality metrics. And they withhold 10% of our income every year, 10% of our contracted revenues. And if we don't meet those measures, then they withhold those funds and don't give them to us on a proportionate basis. So for us, the state funds that we get are around 150 million. So they hold on to about $15 million till the end of the year. It is enough money to get your attention. And that's their approach to incentivizing cost savings and quality of care approaches, because if we don't provide quality of holistic care, then we can be in some pretty significant trouble. And it aims to improve patient-based health and reduce cost, as opposed to just strictly driving volumes and numbers and trying to focus on just the diagnosis that's presenting in the exam room. Now, I will tell you, though, when you're even half of your volume are individuals with Medicaid, it is tricky to balance that out and try and find one foot in one world and one in the other. But if you talk about the benefits of this, and this is the benefits, there's some of these are reported that I will share as a leader of an organization that's trying to go down the path of value-based care, share my thoughts around what the benefits of that are from my lens. Increased staff engagement. You know, I was having a conversation with a managed care company the other day, and we were talking about well, I'll be more transparent than that. It was really with a venture capital fund who's looking at trying to create some services that they might sell. And we were talking about kind of this conversation of staff engagement and trying to align them with the objectives of one of our behavioral health home projects. And I said, with all transparency, if you go to my staff, realizing my staff are unique, they are a set of individuals who have signed up to work in a safety net behavioral health system, right? So they are not driven by just financial considerations. They are here because they are passionate about our mission and they care deeply about those in our community that we serve. And so that's a little bit of a stereotype, but I think it is generally by and large true for our staff. So if you go to them and have a conversation about, look, we need to drive costs out of this care. We need to reduce the cost of care for these individuals. We need to try and reduce their unnecessary utilization of emergency services. And they will look at you and with a blank stare, and you won't get any more engagement than you would if you were talking to somebody on the street about this, right? Like that is not what drives them at all. They're not interested in that. They don't want to be wasteful. They're not indifferent to cost of care. But they're not getting up every morning thinking, gosh, how might we save some money here, right? How might we reduce the cost of care? What they get up thinking is, how can I better serve the individuals that are part of our system? How can I better meet their needs? How can I improve their quality of life? Now, I think we all know, or hopefully we're at least learning and getting to the point where we recognize that these things are not separate and apart from. These things are not misaligned. We can do both. In fact, we have a responsibility and accountability to do both. But talking to my team about the cost savings aspects of this is not the path towards engagement with them. Talking about the impact to those that we serve is a huge driver for them. And we just had a meeting similar to that not long ago with our behavioral health home team. And it was a powerful conversation. And I acknowledge the cost savings part. That's a part of, they're the team that with our pilot with one of our managed care organizations, we have a shared savings model that drove a lot of savings and earned us a pretty healthy shared savings payment. And I acknowledge that, and I give kudos for that work and that impact. But it didn't register for them outside of, oh, hey, that's exciting, I'm getting recognized about this, right? So we do also, though, want to think about cost savings. And in my kind of system, and probably others, if you can reduce that cost of care, then you can begin to think about, how might I utilize this money a little more creatively? How might I think about improving housing stability for individuals we serve? How might I think about some of those other more social related costs of or impacts to their healthcare? How might I offset this with some transparency? If it's the state funds and I'm able to reduce the cost of that care, how might I leverage that to be additional compensation for the employees? How might I improve our benefit package, right? How might I find opportunities for those? It produces better quality outcomes. Again, that's where my staff get engaged. That's what drives them. That's what they care deeply about. Gather real-time data to support treatment decisions. When I get to our shared savings plan arrangement that we had in our partnership with one of the managed care organizations, I will tell you that's one of the things that drove a lot of our ability to impact our population and gain some of those savings, was the near real-time access to information. Being able to partner with the managed care organization for access to that, for look into their portal and being able to see that, was powerful. And then reducing spending for future generations. I think this is a lost opportunity for us in this conversation. I think we all know that we don't have unlimited resources. And I think we see the day where our health system is could become kind of unsustainable. But I don't think we think about kind of that cross-generational impact of that. Like, if I think about the money I spend today might impact the healthcare and dollars available to care for my kids or my grandkids, I might make very different decisions around that care and around the choices that I make. But we've disconnected this from kind of the long-range impact and utilization. So I think engaging in the value-based care arrangement and process and discussion can help think about kind of more downstream and long-term impacts of that. All right, so strategic steps for new leadership. So building an adaptive leadership and the tools to help lead. So this is where I think we've spent a fair amount of time and still have a long road to go, right? I don't want anybody to hear me talk and think I've planted some sort of flag of achievement or accomplishment or completion by any means. We are a learning system. We are still driving down this path ourselves. There are a few people who want to talk to us about some of the stuff we've done because we've had some successes. And at times, frankly, that feels a little awkward because I feel like we're still not anywhere near where we need to be, much less at a place to share with others. But yet this is where we find ourselves. So understanding quality metrics and population health management. Right. So as I think about my team, I think about my leadership team, and I think about my care delivery team, the 2,600 employees that show up every day here at the Harris Center. They are really, really, really good at showing up at somebody's home, delivering care coordination, delivering therapy, seeing a patient in an office, seeing a patient through telehealth. The focus on the individual and that individual's needs is powerful. They are good at it. They're very capable. They deliver time and time again in improving the circumstances and health of those individuals that they serve. But thinking about that at a population level is not a strength they have. And frankly, it's not a part of what their education system is developed, right? I see several people that are clinicians in the room. I know my training, which has been further back than I might want to acknowledge. But as I did my clinical training, I remember it being pounded into my head, the individual approach to care, the individualization of the treatment planning, the individualization of the goals. In fact, I went through an audit. I think I saw at least somebody signed up from Optum. I don't know if they're in the room or not, but Optum just did a quality of care review with us, and they reviewed 10 charts and gave us feedback about how we did and the opportunities that were there. And the thing we got dinged on was several of our treatment plan goals seemed to be copied and pasted. They didn't like that. There wasn't enough variance in that, right? And so the whole focus and engagement around the individual engagement and treatment and care of people, I agree with it. I think it's clearly important, but it doesn't lend itself to a quick pivot to thinking about a population, right? And how you're going to engage a population and think about the health management for a population. And quality metrics, I remember in my counseling program, we had one statistics class. It was brutal. Everybody waited till the very end to take it, right? You just were trying to get through it. Nobody wanted to be an A student in that stats class. Everybody was happy getting out of there with a B. And so pivoting our thinking and reframing this. Again, to me, helping reframe it in terms of how do we improve the care we deliver to individuals is the secret to that. Say I'd like to improve your understanding of quality metrics is not anything that anybody's going to get excited about. But how might we use data to inform our care and improve the outcome for those we serve? It's a little bit of enthusiasm. They're not over the top about it, right? But it's a little bit of enthusiasm there. But what I also find is a lot of my team members are not really data literate, right? Like they are not going to talk in sophisticated ways about data and data quality metrics and the impact of those. So one of the things I do from a practical standpoint is I sign up for almost everything we can related to that, right? Like if you look at MIPS and some of the provider reimbursement components and incentive payments, they're small for us. I already mentioned we don't have hardly anything outside of Medicaid. And so from a Medicare standpoint, the reimbursement for those measures for us, I think it would, if we didn't do any of it and didn't get any payments, I think it would be like $40,000, right? So it's not a big dollar amount that's going to drive it, but the experience is critical. We take those same quality metrics and make that a part of our board quality scorecard, at least to some degree, not all of them, because some of them are pretty far in the weeds. And we drive that conversation around quality metrics to our board so that our board can begin to understand the importance of thinking about how we measure and manage care, and then how we want to apply that on population health management. I'll tell you another example around quality metrics and how you might link that. So we have in our strategic plan a care pathway goal. We actually intend to create 3 clinical care pathways for our system. If you're not familiar with that, I bet most of you are, but if you're not, it's around using evidence-based information to help guide your decision-making in a clinical pathway in which individuals traverse through a course of care being driven on a diagnosis or a situation. And so our first one was suicide. We wanted to create a clinical pathway around suicide care. We also wanted it to be multidisciplinary, not just lay all that weight on our physicians, but think about if you're doing an assessment, if you're an LPHA, if you're a care coordinator, and then the different pathways. And so one of the ways we've got a quality metric around the adoption adherence rate to that clinical pathway. And so using that as an indicator of quality, because if we've all agreed this is the path we want people to traverse, and this is the different decision-making processes and ways we want to drive that care, then adherence to that is an indicator of us adhering to what we viewed as a quality pathway and a quality decision-making tree. And so our second one is around substance use disorder. And our third one we're thinking about around the decision around how and when to engage individuals with intellectual and developmental disabilities who also have a co-occurring mental illness because they have some very challenging circumstances. Understanding and contracting and payment methodology and how it drives clinical care. So I will venture a guess that almost none of my leaders have ever even thought about what our contracts look like with managed care organizations, other than we might say to them, hey, this is a measure that we're accountable to in our contract. We need to make sure that we achieve this 7-day follow-up or this 30-day follow-up, or we're concerned about readmissions because we've got some incentive related to readmission rates or something. But them thinking about what our contracts look like, much less how payment methodology might impact the care we deliver and how it might prioritize it. So try to begin to evolve that understanding. Recruitment and retention of the right people for change, right? So I'll talk in a second about overall adaptive versus technical leadership, but ensuring that you've got people who've got some vision. And again, I mentioned earlier, we have people with 1 foot in the value-based care and 1 foot in the kind of fee-for-service model, and finding people that can live in that shifting sand of that and have a vision forward and understanding the constraints of the current world and being able to anticipate and plan for the future are tremendous, and they're valuable. So you've got to find ways to keep them because other people will absolutely want them to be a part of their team. And so finding ways for that retention is critically important, especially when you're in a system that will probably talk more about the non-value-based arrangements around the fee-for-service arrangements and the historical approach, because that's what the language exists around, and that's where your focus traditionally has been. So trying to make sure those people feel the love and have the attention and the opportunity to shape the direction is critical. Engaging consumers, meeting expectations, and cultural competencies are also critical. leadership skills. I will tell you that the community mental health system has not always been a bastion for patient-centered care, consumer-based care. We have often set up systems, I think often because of a lack of funding and lack of resource. We've tried to set up systems that were as efficient as possible. And that efficiency usually means it's convenient for us, but not often convenient for the people that we serve. And so how might we do a better job of having patient-centered care, having patients want to engage in our care, patients being able to engage in the ways that they want to with our system. I'll give you a quick example for that. And we're midstream on this. We are not fully living in either world, but literally in the change as it's happening. We've created a portal for individuals to receive care virtually, multidisciplinary care. And our target is within the next year for us to have that to be on demand, so that they can pop into that portal whenever they want. They can have an eligibility assessment. They can have an intake assessment. They can have a therapy session. They can see a provider, all based on when they're available and kind of at their demand and request. We're not there yet. We have the care delivery. We have all those different disciplines involved. The on-demand piece is a part we're struggling with right now. We're still trying to we're using this next budget year and budget process to align for next year to be able to do that, which blends into the new technologies piece, right? Not only the telehealth delivery model piece of that, but the other technologies, right? There's a couple of new FDA approved interventions that are out there leveraging technology. There's all kinds of unapproved self-directed and self-guided technology approaches that are out there to care delivery. We've provided some to our own workforce, trying to help improve their access to supports and wellness. And they tend to be a little more focused on wellness in those buckets. But thinking about how we're going to leverage those further into our communities, and particularly in a scenario where there's really not a way to pay for that in a fee-for-service model, right? So we're going to have to find ways to support that using other approaches and others. I would say at the end of the day, and the bottom of it kind of gets into this a little bit. For me, it really comes down as we're thinking about leaders and leadership in this space, do their values align, right? I mean, they're as smart as they may be, as clinically capable as they may be, can they get around aligning to this as a set of values that will drive what our system begins to look like into the future? Just a quick question check. Are we good on questions? Do we have any popped in there?
No questions in the chat, but if anyone has any, feel free to type it in or unmute yourself.
Absolutely. So, hiring the right leadership to empower leaders to transform the change needed in this new environment with a different type of change style and leadership is required. So I spend a fair amount of time, even outside the context of value-based care, talking about technical change versus adaptive change. I think it's an underappreciated differentiation. And I think often our leaders are not well equipped to lead adaptive change. And so if you're not familiar with the context, technical change, this talks about the use of a new EMR. I'm going to go more simple and at risk alienating some of our newer workforce entrants here, but I think you can appreciate it. And that is even adopting a computer system, right? So I can remember when I got my first computer. That's a little scary, but I can remember at work when the first one showed up. And before that, I had these progress notes that I've been writing by hand. I was a dutiful clinician. I made sure I got my documentation done every day. I tried to do it before I went home. If I did a group in the evening, I would do it the next morning when I came in. And it was a smooth process. I had it down. We had these charts, and you'd call them for medical records, and you had to have the appointment scheduled at least a week in advance because they would have to come and get them and bring them to you. And then you'd fill out your chart, put it in the chart and send it back off. And I was very comfortable with that process. I knew it. I knew how it worked. And then they came in and said, here's your new computer, and we would like for you to use this computer to type your notes. Now, this wasn't into an EHR. This was just, they wanted the notes typed so you could read them. And they still wanted you to print them off and put them in a chart, right? And so I thought, okay, well, I'll try it. I was dutiful. They gave you a training on how to operate the computer. They gave you a manual that was really thick, and you could go to a class if you wanted to go to it. And they had taken keyboarding classes, and there was all kinds of work. I sat down dutifully. At the end of the day, typed my note, try to get my documentation done. And for the first day or two, I did it okay, right? And then the third or fourth day hit, and I was tired and I was behind, and I hadn't some of these expectations were my own, right? But I hadn't dutifully gotten all my documentation done. And I thought, you know what, I'm behind and I don't have time for this. And so I set that computer aside and I got my piece of paper out and I wrote my note down and I signed it and I put it in the chart. And I did not go back to that computer for quite some time. They had successfully created the information to create a technical change. But what they had not done is address the adaptive components of that change that was needed. I didn't have a belief that I needed to use the computer. I didn't see the value in that. I didn't understand how that might prepare us for a future world. I didn't understand why it might be important to actually read the note I'd written, as opposed to probably the chicken scratch that was on the piece of paper. And so they had given me all I needed to know to make that technical change, but the change failed because I set that thing aside and it began to collect dust because they hadn't addressed the adaptive part of it, right? The change in attitude, the change in beliefs, and the habits that would need to be there. So now ultimately, obviously, we kicked in and we figured it out because I'm here joining you today, and nobody had to come log me in or get me set up for this, right? So we were able to accomplish that, but part of that is because I have begun to appreciate the adaptive change and what is required for that, and preparing a team around that. The other concept I'll mention around kind of leadership to manage change is the idea that getting our teams and our leadership in particular comfortable with the concept of continuous change, right? I think before, historically, and in all fields, not just ours, we were used to the idea of episodic change, right? And the EHR is a great example of that. We just went through an EHR implementation about 3 years ago. Epic is our EHR. It's a great tool. It's a complex tool, but it's got all the things and all the bells and whistles we could ever want. And so I didn't do a great job of preparing our team for this change. So I prepared them for the technical change. I prepared them for the adaptive change. I unfortunately didn't think about helping them understand that the implementation of an EHR is not an episode of change. It's a continuous change process. And so we went live. We had our launch date. Everybody was excited. We had a party. We had snacks. We had t-shirts, literally t-shirts and pom-poms and all the to-do that every big system does, following Epic's kind of guide on how to implement successfully. And then if you've been through an EHR implementation, the inevitable happens, which is they realize that stuff moved. I don't know where this is. I don't know. How do I get this? How do I get this report? Oh, wait a minute. This is in there now. I want a report that includes this. Wait, how do I do this? Where do I go for that? And what they answered in many cases was, well, that isn't in this version, but we will make a list of enhancements. Optimization is what Epic likes to call it. Most IT systems call it an optimization list. And then I think, and I didn't do my team a good service then, I think they thought the optimization list would be fine, finite, right? There would be a list of 20 things and they would do those in the next 3 weeks and it would be done. And so we could say, okay, we implemented the EHR. Okay, we did our optimization list and now I can get back to normal. And the truth is that this list isn't ever evolving. The list is long. I think right now we're prioritized out for the next year on that optimization list. And there are more things that come in on that every day. And so helping our team begin to realize that we're not going to have this, we're all going to take 3 steps forward at once and then stop and take a deep breath and not change anymore, right? It's going to be continuous change that we've got to prepare our team and our leaders to be able to manage and cope and deal with. So a part of the attributes that help with that is vision, worth, and will throughout the system. And know that this is leadership, not necessarily management, right? So I think we all can appreciate that we have leaders at all levels of our organization. Some of the people who are most able to move teams and get things to happen are not formal leaders in our system, right? They're opinion makers and they're influencers for sure, but they're not formal leaders with the leadership hat. And so helping them at all levels be able to do this, talk about the impact, talk about the outcomes, talk about how we're going to measure it. Talk about those change in values that are required if you're going to do an adaptive change. Thinking about how to give authority to the team and how to think about transitioning people from disengagement to engagement. So huge factors. Selection of people is critical. I think it's something that is an underappreciated skill of most leaders, is how to select talent, how to pick the right people. Often we get wrapped up in, I've got to get this position filled. I need to get somebody in here to help me with this. You know, we think about it from our own workload standpoint, or maybe even from the workload of our team. And so we feel pressure to get somebody in, and we don't always place enough emphasis on fit and what skill do we need to make that next transition. I'm sorry, I'm moving your pictures around on the screen. If it looks like I'm doing something, it's trying to make sure I can see the right parts of my screen. So leadership challenges to value-based care. So for most systems, particularly behavioral health systems, part of it is, how do you manage the startup costs in this thing, right? Like it was one of the conversations we had with our managed care partner around the shared savings model, is they were willing to reimburse us our costs and they were willing to share savings with us. But we felt like if we really wanted to make an impact, we were going to have to invest more than what might initially be viable and be covered. And so how do you do this knowing that you may not recoup that cost at all? Or if you do, it's going to be downstream, right? We couldn't look back and get that shared savings payment until we were a year out from that investment. And so how might we manage that financial burden and challenge associated with that? I mentioned earlier kind of the challenge that comes with being a small organization. I'm convinced it is much, much harder to run a $30 million organization than it is to run a $300 million organization. Having done both, at least at some level of leadership in two different sizes, like I said, the miscalculation on $2 million for a $20 million organization is catastrophic, right? Like it's hard to survive that. If I do it, it's bad. And people may hold me accountable and they may say bad stuff about me, and I may be embarrassed and I may have to go and have hard conversations with my team about the consequences of that, but we're not going to shut down over it, right? We're still going to be there tomorrow. We also have to realize we are a relatively small part of a very large ecosystem, right? And so those disproportionate drivers of cost that we talked about and the disproportionate life loss causes people to look to us to help be a part of the solution. And I think rightfully so. But those drivers, if you look at it, and Milliman has another study that came out more recently, the drivers of those costs are not behavioral health spend. The actual behavioral health spend is a very, very small portion of the total healthcare cost. So those PMPM costs for people with asthma and COPD and those other pieces, it is still the healthcare cost that's driving that spend. And that's where the savings is. The savings isn't on the behavioral health side because we're not the components that make up that additional cost. But yet I do think we've got a piece of the solution, then we can be a help to that greater piece, obviously. And so that's why you've got to think about that shared savings and the value broader than just the behavioral health spend, because there's not that much to save in the behavioral health spend. That's not the big drivers of it. There's a little bit on the inpatient side, but it's inpatient psychiatric side, but it's not huge. Challenges around trusting partnerships with managed care organizations. I feel like I can talk equally about both sides. I spent several years working for both medical cost containment and a managed behavioral healthcare organization. And so I have, that's aged experience now. It's been 15 years since I worked on that side of the fence, but I did, and I understand it, and I kind of understand the lens. And I don't think we have great trust across the system, right? I don't think we give each other the benefit of the doubt. I think in some cases we haven't always acted in ways that deserve the benefit of the doubt, right? I know there have been times where the system has not always been sensitive to our care delivery decisions and the impact of those decisions, and making sure that we invest the healthcare dollars wisely in delivering that care. And I think at times the payer side has not always been attuned to what is the right and best care for the individual and how do we get them the right care. I think all of that is shifting. I think as we move towards this value, I think that is a different dynamic today. But we've got 20 or 30 years of experience operating in ways where we weren't well aligned. And so we've got to figure out how we overcome that. How are we going to give each other trust? How are we going to try and get to that new model? And then the fourth item down here, we're talking about making a pivot to a differently oriented system, but we don't really know how to operationalize that, right? Like we've got some vision as to where we want to get, but our leaders have not really been adept at having a roadmap in order to be able to make that transition. And so how do we operationalize on this? How do we execute on it? And some of those individuals that had the vision and skill to help create that path, they're used to operating in ambiguous circumstances. And they're comfortable in that ambiguity, but our team members are not. So helping them figure out, how do you take this ambiguity that is a strength for you, being able to operate without some parameters and without as much definition and concreteness, but how do we then begin to operationalize and make it concrete and direction oriented for those individuals that need less ambiguity to operationalize the model of care. So for us, this is all kind of integrated. Sorry, that's a double use of the word. All this is wrapped up into an integrated care approach for us. We think this is critical towards if we're gonna be successful in a value-based arrangement and having that impact, it's got to be about better integration across the care delivery for our individuals. I see a couple of chat entries. I just want to make sure see if those are questions I need to pause for, or if they're just comments that are being placed in there. I'm guessing not, so we'll keep going.
No, so far.
Okay, great. Just want to make sure. As I saw the number get to 8, I thought, I don't know what that is, so I better ask. So the impact of building an infrastructure around integrative health to improve outcomes. So I think we all can appreciate the need for integrated care. I don't think there's any ambiguity about the importance of that. I think we have spent a lot of time thinking about integrated care in primary physical health systems, and not so much of what that looks like in specialty mental health systems. And I agree, for many, many individuals, the right answer is certainly to integrate behavioral health care into the primary care system. No doubt about it. Wholeheartedly agree. Have worked in a hospital. I worked in a hospital district before I came here. I've been here at the Harris Center for almost 6 years. Prior to that, I spent 10 years as the behavioral health leader in a safety net hospital system, and spent most of my time integrating our services into the physical health continuum across both on an inpatient and as well as an outpatient side. So I wholeheartedly agree to that. But I do think for the population that we serve, and for those people with more serious mental illnesses, we've got to think about how we integrate physical health care into the mental health service delivery system. And so essentially kind of redefining the specialty mental health system to be able to care for a whole person and be able to meet more of those needs. Now, we're certainly not going to be a specialty healthcare provider and get into all of the nuances. Today, we have about 6 of our locations where we deliver physical health care. And that has to be able to expand for us to really be able to have a meaningful impact in the value-based care arrangement, and to be able to really begin to think about how we improve outcomes while we reduce the cost of care. Removing barriers that limit access to care and address health disparities. These are profound in our system and with our population that we serve. The barriers are significant and they're very, very real. I remember when the pandemic first happened and we, like everybody else, began to pivot to virtual care solutions. We're very proud of our ability to switch. We moved in about 2.5 weeks. We moved of our 2,600 team members, about 1,100 continued to deliver face-to-face care in crisis and 24 care settings, and about 1,500 began to deliver care virtually and remotely. And we were super proud of that until we discovered that people weren't keeping appointments, right? Our no-show rate, even virtually, was significant. And everything you had seen said no-show rates improved a little bit. So we started doing a kind of a social determinant of health questionnaire to our team members, trying to better understand what their needs were and what was happening with them. Also trying to understand the impact of the pandemic. And what we began to realize is that while a lot of our clients, patients, consumers, pick your word, we have different ones we use ourselves depending on setting sometimes. They had access to smartphones. They absolutely had technology available to them. What we didn't appreciate was that, unlike my smartphone and my plan, I have an unlimited plan. I can use as many minutes as I want. I use as much data as I want. Theirs weren't, right? They often had contracts or payment arrangements where they prepaid their cell phone, and it came with very limited availability of data and minutes with their plan. Some of them even still had antiquated plans where they didn't even have unlimited text, right? So while they had access to the technology, which we thought they did because we saw it, they used it at times, we didn't appreciate the fact that they were much more challenged to be able to do a virtual visit because of the data consumption on that plan. And they may not have access to Wi-Fi at home. They may not have internet access to that. And so, again, just a very real, with some of our individuals who still wanted to come to the clinic, because they access care in person because they walked over to the clinic, right? Trying to remove, you heard me talk about the virtual. We also introduced walk-in availability because some individuals need to show up on the day. If they do day work and they work outside, they may choose to get care when it rains because they're not going to be able to go into work that day. So trying to really think about what are the barriers that are out there and how do we begin to impact those. Improving overall health and well-being of all vulnerable and at-risk behavioral health populations for preventable hospital and ER admissions. When we did begin to look significantly at how we reduce cost of care, those two categories of cost were huge drivers for the population that we were assigned, and that were attributed to us in our shared savings kind of a model and arrangement. So trying to figure out how we connect with those individuals, how we coordinate care, how we help them begin to make health decisions that are proactive rather than reactive and often result in hospital and emergency room visits and admissions were critical for them. So components, Optum Integrated Behavioral Health Care is our shared savings model that we entered into. There's other arrangements. We have some other arrangements, none as robust and significant as that. Optum attributed initially about 1,500 members from their plan to us. They selected those members based on the highest cost of care. So they took their 1,500 most expensive members and attributed them to us and said, go forth and see if you can engage them. Some of those individuals we brought into our system of care, some of them continued in other systems, and we just provided care coordination. But that for those that we brought into our system, and even those that we just coordinated, integrated care became key for our success and for our impact. Behavioral health integrated in the primary care setting, access to specialty care when they need it. For us, integrating physical health care into the behavioral health continuum, embedded care coordination, no matter who or what their provider system was. So whether we served them, whether some other system served them, we became their care coordination, working in partnership and collaboration with any care coordination function that was happening within the managed care component. I mentioned earlier access to the technology and the data, and the data analytics. So the managed care organization was able to help us identify those they saw as rising risk. They were able to help us use their information portal to identify those individuals that were receiving emergency care now or had been admitted to the hospital, near discharge from the hospital. We did outreach and engagement even when people were in those settings, trying to connect with that. Obtaining additional funding. So I talked about that risk associated with the gap in success. And so we tried to find strategies of how can we fill this gap. Episcopal Health was a great partner for us. They helped provide additional funding to help us close that gap. They even offered us a little more than what we initially asked for because they wanted us to be able to have adequate resources to make those investments, to provide self-monitoring tools, to be able to provide, to send them blood pressure cuffs, to be able to help us invest in the staffing we thought we needed to be successful. Establish a robust EHR. As I mentioned, we have Epic. It's a huge luxury for us. It's a huge investment that was made. And I say by us because part of it was by us, but also the county helped offset some of our cost of care, cost of EHR, because they believed that it would result in lower cost of care if we could share information and data across the system. Harris Health is our EHR partner. We are a community connect point for Epic. That's how we were able to leverage it. And even though it's as expensive as it can be, it made it at least reasonably affordable for us by leveraging their relationship with Epic. Compass Rose is a part of that solution, taking into account 7 non-medical drivers of health, being able to track HEDIS measures through the Optum data, and the closed loop referrals on those were really, really helpful because those were the measures essentially. If you take our model, I'll make sure it's not next. No, if you take our model of shared savings, what it essentially accounted for is we got paid a PM for all the members that were engaged. Then they tracked the cost of those members, looked at the reduced utilization of those members that were engaged, reduced the PMPM payment that we had received, and then we got a portion of that savings based on the achievement of quality metrics, right? So you don't want to just eliminate cost of care. That's pretty easy to do, frankly, but you don't enjoy short-term incentivized, but long-term and prudent to reduce that cost. And so, so those ability to track and monitor those measures were critical. So what is a health home? For us, a model of patient care that utilizes team-based approach and emphasizes care coordination, coaching, advocacy, provide quality care, help lower medical costs, and achieve an excellent patient care experience. So we've spent a fair amount of time trying to create a health home that is essentially a behavioral health home. The partnership with Optum allowed us to bring that to scale. We've since done it with some non-Optum, non-insured clients, trying to continue that push through. So if we can reduce the cost of care in that setting, how might we be able to apply those principles and reduce cost of care where we might have some level of risk in that, because we only get so much state funds to provide the cost total care that individual needs. Health home standards. I came from a setting where every one of our outpatient clinics were health homes, designated as such. So these are the things that are kind of expectations and standard requirements associated with that. And then this is where the behavioral health home kind of fits within SAMHSA's model and vision of kind of the continuum of services. Most folks we've spent a lot of time, and rightfully so, talking about CCBHCs. We are a CCBHC. We're designated as one. We have been now for 3 years, I think is when we first received our designation. Understanding those for those that are out of state, we've adopted the CCBHC model, but we don't have the prospective payment mechanisms that go with it. So we have all the obligations and none of the money. So don't even ask me why that is the path we chose, but we did. And I think we've got some good outcomes for it and good measurements for it, but it really isn't kind of a health home. It is a behavioral health service delivery system that's comprehensive. And there are some linkages to primary care screenings, but it isn't a place where they can receive the care that they need in most cases around that. Integrated care, I think it's represented here fairly and appropriately. Anything less than 4 and 5, I don't really get that excited about in terms of an integrated care model, and certainly better than co-location, but I think that's the minimal level of viability in terms of that approach. And then you can see the behavioral health home and integrated care behavioral health home plus in terms of the other components under one roof. And we're getting awfully close to the integrated care behavioral health home plus. We are in the process now of an evaluated process of becoming an FQHC lookalike, so that we have a model to be able to make the physical healthcare that we do in our system more sustainable. I mentioned to you that we serve around 90,000 people a year. We serve about 2,000 to 3,000 of those with physical healthcare services, with primary care kinds of services. So with that, I'm going to pause and take this screen down so we're kind of back face to face. There's my contact information. You need that. We do have an app that's available. It's just kind of informational and helpful. But if you want to grab a quick picture of that information, you can have it there. I'm sure the organizers can also help us connect if you have a need to reach out to me. But with that, I will pause and, like I said, come back to us face to face for some dialogue. We had a few more people jump in the room, I see, while I was talking. So it's great to entertain any dialogue, or if you've got things to add. Like I said, I don't proclaim to be the all-knower of this stuff. I'd be happy to allow others to share any insights that they may have around the topics. I see the discussion about the Milliman report. I'm going to pull it up real quick on my desktop. I'm not going to try and share it. There is a report that was issued by Milliman. I think it was, trying to find the date on it, very recently, but it's the economic burden of mental health inequities in the United States, which I think is powerful, and it gets into a lot of that kind of information around that. And then there's another one that is pretty powerful. No, it's not that one. Sorry about this. I didn't intend to cite it. I'll find it and post it in there. I don't want to. Oh, it's 2020. It's how do individuals with behavioral health conditions contribute to physical and total healthcare spending? and it was done by Milliman. It was commissioned by a research group. August 2020 is when it was released, and it's powerful. It talks about the PMPM cost. I think the average insured person's PMPM cost was around $6,500 for a person with a serious mental illness. I think it was around $20,000. And if you have a mental illness and a substance use disorder, I think it was 22. Those are top of my head, so I may be a little bit off on those, but it was powerful insights into what the spending looks like, and the percentage of healthcare spent by this subgroup of people with serious mental illness. High cost. They break it down into high cost members. But great report. Take a look at it if you get a chance. Anything else we can talk about or share?
Yeah, Wayne, I've got a question.
Yes,
Did you encounter any resistance from board members on to the transition to value-based care?
I mean, that
And how did you handle that?
I'm still handling it, Dan, to be honest with you. I did. Interestingly enough, so I have an interesting board. My board are appointed by our county commissioners. So I'm a government entity, and so the county, I'm not a county department, and I'm not a part of the county government, but I'm sponsored by the county. And as such, the county appoints my board. It is a very unique board in that they are political appointees, but also have experts, providers, former hospital administrators, people who are really savvy and knowledgeable. And I had a couple of board members who had a very traditional view of managed care, which was more adversarial in nature, right? And they're like, no, we got to go fight them. We got to, I'm like, look, this is the direction that the field is going. We can fight it if we want to, or we can try and lead it and steer it, right? And so, and even into the behavioral health home conversation, there is conversation today. I mentioned that we're exploring FQHC lookalike status, and there is concern from them. I don't even know if it's so much about the model. A lot of their questions have been around the governance of the model, right? Like if we do create, because we'll have to have a co-applicant board, because if you're an FQHC or lookalike, you've got to have 51% be consumers and users of services. And my board are not that, they're political appointees. And so we'll have to have a co-applicant board. And so it got into conversations about what does the governance look like and how are we going to manage that? And not in a power way. I don't think it's about, I think for them, it's about knowing that they're doing their diligence, that they're meeting their fiduciary obligations, and that they're providing the leadership to my system that they've been appointed and feel a strong responsibility to do. And so, so I have, in each of those conversations, it has been a walking kind of conversation, right? Like we got into it and that conversation around the lookalike application status. I realized I had not done a great job of setting the why part of this conversation. So I did that for them last. The next steps are around governance and financial modeling, right? So I'm going to literally walk them through each component of this conversation as they help steer it, as they say, hey, here are my concerns. Okay, great. I got your concerns. Let me go back and help find ways to address, speak to those concerns, or in some cases, if they're just a risk that we're going to have to manage, then let's do that. On the value-based care, there was, I think the only way probably that I got there, not that I needed they don't sign off on our managed care contracts, but the way I was able to overcome their concern was the fact that there was no risk absorption in this for us. As a government entity in Texas, I cannot absorb risk. It's not allowed. So I can't take risk on in the traditional way. And so I was able to reassure them that the PMPM was covering our cost. We had a grant to supplement that cost coverage. And then it was just all upside. And part of that was with our agreement with Optum is they would still pay me fee for service for any services delivered. So it wasn't as though I had to make a complete pivot and just rely upon the shared savings. So I was able to communicate to my board at the end of the day, our costs are covered. And so this really is about, can we improve outcomes and reduce costs? And if so, we'll have upside only kind of advantage. And if it wasn't for that, I don't know that I would have been able to sway them to overcome their concerns. Again, they didn't have to sign off on it. But that was the key point. And then the way that I helped get a little more vision alignment was to be able to say, like, look, we can talk about our ability to reduce cost of care all we want. We can talk about our ability to improve outcomes. But I believe with some certainty that payers trust other payers' opinions, right? On if a group can save money and can improve outcomes. And so The check in the mail was the ultimate endorsement, right? In my opinion, an assertion of it doesn't carry nearly as much weight as, and we've made presentations with Optum. We've been at conferences. We presented our data and our outcomes pretty transparently. I've been surprised that they were willing to be as transparent as they were around this, but they were. And so we presented it in multiple conferences, and that begins then to help me have other conversations. I was at a presentation and just had one slide about it. And then another MCO that operates here in our market in Houston reached out and said, hey, how might we think about this value-based conversation? Is there some need that we might be able to think differently about how we achieve that? And so helping the board see that perhaps if we're able to and willing to take a couple of chances, we might be able to further the conversation on behalf of our consumers with other organizations as well. But that's a great question.
Great, thank you. I've actually got another question too. In your conversations with MCOs, have they recognized that the population that a CCBHC is serving is different from the physical health clinics that they have value-based contracts with? Or are they comparing overall just these are our value-based contracts with providers, and do you get compared with the physical health integrated care systems?
So it's a great question. So in this, for the most part, we are compared to other community mental health centers. And I think that's because historically the behavioral health has been carved out. As they begin to carve that back in and manage that all as one, I think there's going to be more and more chance that happens. In this model that I talked about with the shared savings, and there are others, they tend to be more kind of outcome driven around HEDIS measures and some of that kind of stuff. But in this one, where it was really about cost of care, we had the luxury of this was their pilot. They picked 3 sites to be pilot sites across the country, and we were one of the 3. And so they acknowledged that they didn't really have a comparison.
That's awesome. Yeah.
But these were members that were, and I think they would acknowledge the cost drivers were on the physical health side. So thinking about how we engage compared to others wasn't all that helpful. They were just trying to find some solution, right? And if you think about it, I mean, these members, I don't remember the threshold. I think most of these members were costing at least $6,000-7,000 per month for them. And so these are really, really high cost individuals for them. And so I think there was a willingness, kind of let's try something, right? Like it's not working great as it is, so they don't have much to lose kind of thing. What's interesting about them, and if anybody is here from Optum, speak up. I won't embarrass you. I'll only say good stuff. But I just want to know if there's anybody in the room so they can have a chance to talk if they're familiar with it. But I was really impressed. Speaking of that transition and need to get away from this kind of adversarial dynamic and conflicted arrangement, they assigned a project manager to this. Now, I was suspicious of that project manager in the beginning, right? I didn't have full faith that they were operating in our all best interest, but they were. And as we began to encounter challenges, they help problem solve, and they would go back to their team and say, hey, this is a legitimate challenge that we're facing. How might we support them in that, right? That's where the access to real-time data came. As this project evolved through the first year, they actually changed their allocation methodology. They expanded it. The attribution piece, originally our arrangement was we were paid based on people that enrolled, people that kind of officially signed up to be a part of our process, our program that we had here. And what they realized is that pretty quickly, very traditionally, if a member said no, we moved on, right? Because there's no revenue for us in that scenario. And I don't mean that to sound cold-hearted, but we were trying to make sure that we covered our costs, right? And they, though, didn't want us just to move on, right? They want us to keep trying to work towards engagement with some of those individuals. And so they came back around and said, hey, what if we change the methodology of attribution? What if we don't pay you PMPM on registered members, but what if we pay you a smaller PMPM on all of those members that we want you to engage? Same dollar amount, right? It worked out to be the same amount roughly that we were earning PMPM on signed up members. But now we could be challenged to continue trying engagement for everybody. And that seemed to be positive for them and for us. I think they also realized that there were some real simple things we could do to impact cost of care that didn't really require somebody to be signed up for. Like, I'll give you a really concrete example. When we would engage with somebody that had a high ER utilization, and that was driving a lot. Our first call with them would say, we'd describe our program and talk, and we got fancy brochures and slides and stuff we would try and talk to them about. But if they'd say no, they would say, well, before you go, we've seen, we know that you've been going to the ER quite a bit. We took a look, and looking at the map, there's 3 or 4 urgent care centers that are much closer to you than the emergency room is. And our experience is you wait much less time than you do in an emergency room. Do you mind if we send you a map of the urgent care centers that are in your area? Right. And they'd say, sure, you can do that. They wouldn't sign up to be a part of our program, but they would agree for us to shoot them an email with the urgent care centers. And then you could watch the cost of their ER visits drop as they would engage in urgent care time for some people. Right. And so, I rambled far away from your question, but at its core,
Those great examples.
No, but they became flexible. And I think the spirit of your question is, are they willing to be flexible, or is it a one size fits all kind of mindset?
Yeah.
And in this project, it was very much a flexible mindset. And Optum came and they spent 3 hours with us. Their top leadership, their CEO, the president of their behavioral came in and spent some time with us, and they seemed genuinely interested in how might this model be replicated in other settings in other ways.
Excellent. Thank you.
It's a great question.
Wayne, I know, Dr. Gibson, you have a question, but I just got David put it in the chat. Isn't the total cost of care very difficult to measure for community clinics?
Yeah, I'd never be able to. That's why they do it. The cost of care is I've got some trust that they're reporting accurate cost. And their cost of care, they're the payer, right? So they know what that cost of care looks like. They know the pharmacy spend, they know the acute care spend and the ER spend. So they're the ones who calculate that reduced cost of care. We're not able to do that. Would never be able to. But it does again speak to the need. The people with the most information about those we serve are not the people who do the serving, right? The people who have the most information about it are the people who are doing the paying. And so figuring out how we combine those two have been critical. And like I said, they give us access to a portal. We had to sign, all kinds of things in blood that we wouldn't over disclose, or we wouldn't use it for bad purposes. But I have multiple people with real-time logins into their portal. I'm sure they've got some filters that don't let us see stuff we're not supposed to see. But they were very accommodating in trying to help us gain insights from the data that they have and information they have on consumers.
You've kind of answered some of my question, which has to do with, it's kind of a chicken and egg situation with value-based care, because you really need a payer to change the way they're paying before the providers can change their operations. Yet at the same time, like as you're saying, Optum, it's like, oh, that whole thing about trusting the other side. So I don't know if you can say even any more about that, about how to get started, or.
It was really, really challenging. Honestly, it was the contract negotiation itself was challenging, right? Like my contract people were ready for a fight. They didn't trust them. Every word was criticized. And at the same time, this was so new. To their credit, none of us knew the right stuff to put in there. We didn't know how to protect ourselves. They didn't know how to protect themselves. At the end of the day, with some degree of frankness, this is a leadership conversation, right? I said to my contract people, I want this done. I want this arrangement to happen. I want it to go forward. Protect us the best you can, but I want this to go forward. Nobody said they were from Optum, so I'll tell y'all a secret. On this first one, I might have been willing to do it for almost nothing, right? Like I'm willing to take a little bit of risk and put myself out there. I don't want to lose money, but I want to be able to demonstrate or determine, do I have the ability, if done well, to improve people's outcomes and reduce the cost of care, right? I wanted that. So I was willing to expose myself a little bit from a business standpoint to take a chance or two to let that happen. And they had to be the same way. And so it came down to will on both of our parts. But again, I'll tell you, to their credit, and I'm not Pollyanna, I'm not overly optimistic about this and other people's motives and stuff. They came back at the end of the year and said, look, we want to change your contract. And my contract people lost their minds, right? They're like, no, this is our, and they said, well, let us just show you the modeling. And they showed us modeling that showed that if we kept our current terms, they were going to pay us less than what we would get paid if they changed the terms to the way they wanted to. And it was because, I think, in all honesty, I'm not sure it was completely out of good graces. I think they wanted to make sure that we were willing to continue into year 2. And so they wanted that payment to be big enough that it meant something. And we really had done a lot around shared savings. It was where we were getting hung up was on some of the quality metrics. We were having a hard time demonstrating some of our impact on those. And so they wanted to give us less emphasis on quality metrics. And in essence, I kid you not, give us more money. Again, I don't think it was altruistic. I think they wanted us to stay in. I think they saw that there's some real potential here, and they wanted us. The other 2 providers, frankly, didn't get a shared savings payment. So I don't want to act like this was easy and it's simple and you just show up and it all kind of works out and it happens well. There's another entity in Texas and an entity in Florida, and they didn't get a shared savings payment out of the arrangement. So, so I think there was a willingness on their part to revisit contracts and to think about how to make that more equitable for both of our organizations, which is a part of how they demonstrate it, right? And building trust too. So their embedded kind of project manager, they built trust with my team over time, because I'd say, "Are you sure?" And they're like, "No, trust me. They really want us. They want us to be successful. They're trying to help us." They were sometimes a pushback on their system. They'd go to their system and say, "Look, these people are trying. You got to give us some help here. Give us a little bit of flexibility there." And so we found a decent level of kind of collaboration and alignment of goals. I think that probably is what did it more than anything, is we both wanted to reduce the cost of care. They wanted to do it because it would save them money. We want to do it because it would earn us a little bit of money. And I think our commitment to quality, improving quality and outcomes has always been there. I don't think that's ever really been in question. So it wasn't hard for us to be aligned to that part of it.
Hi, this is Victoria Rodriguez. I work for Driscoll Health Plan down in South Texas, a pediatric plan, and I'm the director for population health. I come from a background in the LMHA system. I was there for 17 years with Noesis. And so we are in the middle of addressing some APMs with our local LMHAs. And just some additional insight I wanted to give was, it is helpful to have someone on the inside who knows what it takes to be a CCBHC and all of the struggles inherent to that. But it's also important to remember that the managed care companies are driven by legislature also. You know, we are required to do these value-based contracting up to a certain amount by a certain year. So we're very motivated in working on these arrangements. And you're absolutely right, not only from a win-win perspective, but really from how do we help make you whole so that you can take the best care of our members. So I appreciate your insight in sharing that we do go to the mat for you and go back to the VPs and say, no, this is really what it takes for this to happen, and sharing that information and data so that it can be successful. You're right, it is mutually required, but also beneficial.
Well, and we had a couple of years ago, we had an arrangement with one of the health plans, and it was really around kind of HEDIS measures, right? Very transactional.
Yeah.
And I'm sure it was a way for them to cover a large amount of dollars and lives with but I will tell you, they came to us and they got frustrated with us. And they're like, "Look, you're not performing that well." And I looked at it and I said, the total potential payout is this. Like, that's not enough for me to change the way we do business.
Right.
Try and do that. So essentially, we were picking up some payments here and there when it kind of happened, but not enough for us to redo our focus in the way we do business. And so doing something at scale that has meaningful money in it in a collaborative way we were able to be much more sophisticated and intentional about kind of taking that chance and doing something that looked very different from what it was previously.
Yeah, sometimes it's beneficial to get away from those HEDIS measures because it's so hard to make an impact on those when it allows us so much creativity otherwise, you know, to look at some additional goals.
And I think some of our quality goals in year 2 were not HEDIS related.
Right. Yeah. No, we're not looking at any HEDIS at this point. Yeah, we're looking just at mutual pain points.
Yeah, I think they did it because they didn't know what else to go for, you know, and now we've learned a little more. And so I think we got a little more sophisticated about what that might look like.
Yeah, it's an easy place to start.
Yeah. And I see the question about what can you do when you have 30 payers? It's a great question that I don't have an answer for, David. I wish I did. You know, I've got, like I said, I've described most of my people are uninsured. Those that are insured are mostly Medicaid. We have 3 Medicaid health plans essentially that operate, 4-ish, 5-ish maybe if you really want to get technical. And so it's a much smaller world. But again, I've got a dynamic where most of the other health plans I'm working with are not doing this level, this sophisticated level of kind of value-based care arrangement. And so we're still living in both worlds, trying to find a path for that. And it is a great point about the chicken and egg that Dr. Gibson made. It is tricky trying to figure out kind of how to straddle that and kind of where to go first. And that's why I will say that all upside shared savings was at least a safe point for conversation, because it allowed for us to be whole and try something different. And so, yeah, probably wouldn't have got a year or two if it had failed miserably, but it gave us a chance to learn and grow from that.
Did you have any problem with Octon fully delegating care coordination to your teams as opposed to having their care coordinators get in there and kind of muck it up?
The only problem was confusion, right? So they didn't know, but though there was a directive, there was some sort of notification that they put on that person's file that said they had been attributed to us and that we were the primary entity. Sometimes we would call them and coordinate with them and say, hey, they were confused because you reached out to them. It was never kind of heavy-handed. It was always, frankly, my sense is, and don't tell the Optum folks this, my sense was they were happy to let us do it, right? They were happy to, okay, yeah, this is yours. Okay, this is your person. You take care of it. So it was typically a lack of awareness that we were involved in it. And once we clarified that, they were quickly ready to move on and not be overly heavy-handed and engaged in it. My sense was we were doing their work for them and they were happy to let us, kind of thing. Sense of it.
We're getting closer to the end, so I'm just gonna ask one last time if anyone has any other question before we end this meeting.
I see somebody asked about the PowerPoint. You're welcome to make the PowerPoint available.
Yeah, we're
The
gonna
government entity,
actually,
everything we do is public record anyway, so we're happy to share it.
thank you. Victoria, do you want to talk about the next steps?
Yeah, so I'll be sending out a follow-up email. So I'll include Wayne's slides, and then I'll also include the evaluation survey link. And so by filling out that evaluation survey, that's how you'll have access to your certificate of attendance, which can count towards CEU credit. So just keep an eye out for that email. I'll send it as soon as we're done here.
Thank you. Thank you all for joining. Enjoy the rest of your day.
Thanks for the
Wayne,
opportunity.
thank you
to
so
visit.
much for your kind
Thank
words.
you.
Helpful.
Absolutely. Thank you.
Bye, everyone.